got a different microphone on. I've got a different microphone on. Can everyone hear me? Yes. Yeah. Well, I'm delighted to be here as well. I'd like to thank Joe and the organisers for inviting me. So I'm very happy to be interrupted and for people to ask questions as we go through. This, by kind of definition, does have medical terminology, and the management of MEN1 can be quite complex. So what I really hope to do is try and keep it as simple as possible, but I apologise in advance if there are things that need clarification. So please do interrupt and stop me at any point. So what I'd like to do is just to kind of give the headlines really from the most recently published guidelines for the management of MEN1, which were published last year. And the senior authors on these were Raj Thacker and Maria Luisa Brandi from Italy. And so what's the purpose of having guidelines for the management of MEN1? Well, I think there are a number of different reasons why guidelines are important. Firstly, I think it increases the awareness of MEN1. It provides a framework for clinicians on which to base care. And to some extent, although these are guidelines and they're not a rigid protocol, they do provide some degree of standardization between institutions. I think they're also useful because in putting the guidelines together, they outline areas of controversy and also identify areas where we don't know what the best course of action is. And I think also by providing guidelines, it also provides not just the management of an individual with MEN1, but also considers the wider implications within the larger family. And the ultimate goal really has to be to try and improve the outcome for individuals with MEN1. So these are the guidelines, as I say, that we published last year. And I think another thing to say is that they are, they've been put together by an international field. And that comes with a number of issues, not least that we are dealing with management styles that come from different parts of the world, and there may not always be agreement between what we do in the UK and what we do in the States and what we do in Europe. So this is a consensus between the amongst international leaders within the field of MEN1. So as I said, these update the previous guidelines published in 2001. As I've said, they represent the views of international leaders within the field of multiple endocrine neoplasia, and the way in which we put the guidelines together was to try and undertake a systematic review of the literature. And when I go through, when we're putting the recommendations together, the recommendations come with some kind of clarification. So to say, how strong a guideline should this be? How strong a recommendation should this be? And so some of the guidelines, they're all put together using a system of grading called the grade system. And this allocates recommendations based on whether they're a strong or a weak guideline. And a strong recommendation, we feel that patients are likely to benefit if they follow that recommendation, or clinicians follow that recommendation. A weak guideline, the evidence for that, the likely benefit is less clear-cut. And so although it is the balance of opinion that we recommend this, I think those recommendations do require more cautious interpretation. And then for each of those recommendations, we've assigned a degree of a quality of evidence supporting those recommendations. And what that means is when we look at the scientific literature, what is the evidence to support what we say? And as I'll come on to, there is a problem here, because what we know is that to date there have been very few randomized clinical studies of patient care or of treatment options in multiple endocrine neoplasia. And the reason for that is because it's a rare disorder. And therefore, for most of the recommendations, there is not clear-cut evidence-based medicine based on large clinical trials. Rather, it's based on case reports or case control studies or smaller studies of series of patients on which we're basing the recommendations. So something has gone wrong with this slide. So this is really the point that I was making, to say that there is a lack of evidence from clinical trials that specifically evaluate the treatment methods, the diagnosis and screening of MEN1 associated tumours, and therefore their recommendations are largely based on the balance of expert opinion. And the other critical point is that these are not meant to be a rigid protocol for people to follow. What they are is a guideline for people to use as a template, if you like, for considering what the best treatment options are, and also to provide the supporting evidence for why you might follow these particular recommendations. I'm just going to see if this continues. So if we come on to MEN1, there are 3 ways we can make a diagnosis of MEN1. You can have a clinical diagnosis of MEN1, and that would be an individual who has 2 MEN1 associated tumours. It doesn't say anything about the genetic etiology, it's just purely 2 clinical manifestations, so a pituitary tumour, a parathyroid tumour, and a pancreatic or neuroendocrine tumour. And that would constitute a clinical diagnosis. You could have a familial diagnosis, so this would be a patient who is a relative of someone who's known to have MEN1, who has the first presentation, the first, who develops the first tumour. And again, this doesn't say anything about the genetic basis of it. It would be a familial diagnosis of MEN1. And finally, you could have a situation where someone is known to carry an MEN1 mutation, but has developed no manifestations. And that could be considered a genetic diagnosis of MEN1. And I think it's just worth considering those 3 diagnoses because, as you will know, it's how individuals within each one of those groups may be managed slightly differently. So I'm going to start off just by, I know you've had some talks on genetic testing and the implications of genetic testing earlier in the day, but this is the guidelines, that the recommendations that we've made on genetic testing in the most recent guidelines. So what we suggest is doing the DNA mutation analysis of the MEN1 gene should be offered to all patients with a clinical diagnosis of MEN1, and if they are a mutation carrier, to their first degree relatives. And this includes relatives who either are asymptomatic or already have manifestations. In addition, we should offer MEN1 mutation analysis to asymptomatic relatives at the earliest opportunity, ideally prior to the onset of any biochemical or radiological screening, and we recommend that the earlier this genetic testing is done, the better. And the reason we make that recommendation is that we know that the earliest manifestations of MEN1 associated tumours can occur in early childhood, so as young as 5 years of age. And so although we don't feel there is a right or wrong answer to what age genetic testing should be done, it's a personal choice to be discussed with the families and parents, we recommend that it certainly should be considered at the earliest opportunity. And then we also recognise in the guidelines that we think that anyone having MEN1 genetic testing, this should be accompanied by genetic counselling at the same time to understand what the implications of both a positive and negative result would be. And for those in whom an MEN1 mutation is identified, then at that point they should enter a period of biochemical and radiological screening for the development of, to investigate for the development of MEN1 associated tumours. Do they raise any questions with anyone at this stage? Yeah.
Do you recommend within a family, if for instance there's a 5-year-old and a younger sibling, do you recommend the testing to occur at the same time so that the family are sort of going through the same thing together, or do you get the first one tested at 5, wait a bit longer to get the second one tested when they're 5 or thereabouts? Is there any?
I don't have a strong feeling. I think this has to be a personal choice to be discussed with the parents. Some may find it, I don't think there is a way that I think you just discuss what the implications of doing both children together would be, or to discuss doing them separately. And I think there isn't a right answer to that. I think all we're saying in this guide, in this recommendation, is that we think there is some benefit to doing it early. So at that point, that certainly some biochemical screening could start at a young age. So that if we moving on from the genetic testing to the screening for tumours, so what we recommend is that all individuals identified as having a high risk of developing MEN1 associated tumours should be offered a combined program of biochemical and radiological screening. But the nature and the timing of this screening will depend both on local resources, clinical judgment, and patient preference. And the reason you can see the grading for that is 2 is weak, and the evidence is weak. And the reason for that is, there have been no trials to date to tell us whether screening actually changes the outcome. We all assume that it does and that it's a good thing to do, but there isn't the evidence to support that screening has been shown to be beneficial. But I think all of us who look after patients with MEN1 feel that this is a critical part of the management. And when I say high risk of developing MEN1 associated tumours, that will include people who are mutation carriers and also those who may not be mutation carriers but have got a clinical diagnosis of MEN1, because we know a proportion of people with clinical MEN1 will not carry a mutation within the MEN1 gene that we can identify. So it's not simply those who carry an MEN1 mutation. And then I'm just going to briefly touch on each of the kind of headlines for what our recommendations are for each of the tumours that constitute MEN1. So we're talking about parathyroid tumours, the pancreatic and pituitary tumours, and then briefly on the thymic and bronchial carcinoid tumours, as well as adrenal adenomas. And I think this is perhaps the most important message that I think the guidelines recommend, is that for patients with multiple endocrine neoplasia and their families should be managed by a team that have expertise in managing the condition. And this should consist of relevant specialists with the management of each of the components of the syndrome. And that ideally, as and when MEN1 associated tumours develop, that those tumours should be discussed as part of a multidisciplinary team, which will not only include endocrinologists, endocrine surgeons, it should include gastroenterologists, oncologists, histopathologists and radiologists, as well as the clinical geneticist. So what we're promoting is that a very wide spectrum of medical specialties are involved in the management of the tumours associated with MEN1. Yeah.
Grade both of these 2.
There is no clinical. It is difficult to give something a strong recommendation based on no evidence at all. So what we think we can do with all these grading recommendations are they provide some information about what the background to the recommendation is. So I don't think any of us would say we don't particularly recommend this, but it is difficult to make a strong recommendation without any evidence at all. And we would never be in a position to do a trial to compare looking after patients with an MDT compared to looking after patients without an MDT, because we feel so strongly that we should be managing them with an MDT.
And there's no evidence, there's no body of evidence out there from history that...
Well, I think there probably is some evidence out there, anecdotally, but the evidence that we're looking for, on which you can base recommendations, to give a strong, to give a high level of evidence would have to be a randomised controlled trial. To get a medium evidence base has to be a case control trial, so you have cases and controls. So all of this is going to be is anecdotal, saying we've had patients referred to our clinic who've been managed locally, perhaps not by the optimum specialty, and they didn't necessarily get the optimum operation or treatment. But that doesn't form an evidence base. And this is by no means, as I said, a rigid recommendation, but this is what we have put together as being an example screening strategy for the parathyroid, pancreatic, pituitary, adrenal, and carcinoid tumours. And so for parathyroid tumours, we're recommending that we don't need any routine imaging, but it would be an annual blood test to measure the calcium level in the blood and the parathyroid hormone. That for some of the pancreatic tumours, it can be based purely on biochemical testing, on blood tests, but for non-functioning pancreatic tumours and for other types of pancreatic tumour, it requires some imaging modality. And what we recommend in these guidelines is some form of annular imaging, although that is controversial, as you know, some people would argue that because you haven't shown there's a benefit, there is no clear-cut benefit to doing annual screening, that perhaps that imaging shouldn't be on an annual basis, it should be less frequent. And for pituitary tumours, again, the most common form of screening would be blood tests, but imaging, we recommend imaging on every kind of 3 to 5 yearly basis as routine. And then the adrenal kind of gets covered by the pancreatic imaging normally, because when you look for pancreatic tumours, almost always you will get some information about the adrenal glands at the same time. And looking for thymic and bronchial carcinoids, I think this is probably one of the recommendations we make where probably that imaging does not form necessarily a part of routine care in all centres at the moment, I would say. But that is a kind of outline or a template for an example of a screening strategy that might be adopted. So if we start off with parathyroid tumours, so this is one in which we can give a strong recommendation to say that patients should have an annual measurement of calcium and parathyroid hormone, as the diagnosis of primary hyperparathyroidism in MEN1 is relatively easy to make. And then in terms of treatment, this is where it becomes more difficult, because at the moment, although the type of operation, there is general consensus that doing minimally invasive parathyroid surgery, which by that I mean taking one gland away, is not recommended, because typically in MEN1 several of the glands are involved. However, the difficulty is that the optimum timing of surgery hasn't been defined. And so what we recommend is that we do an open neck exploration where at least 3.5 of the glands are removed, or to undertake total parathyroidectomy, in which case all glands are removed, and that may or may not be supplemented with autotransplantation, which is done in, frequently done in Europe and in some parts of the States. Do those recommendations make sense?
Basing the criteria for surgery on raised calcium and PTH and symptom.
Well, it wouldn't. I think we would, you know, the indications for surgery and with parathyroid disease, we will be looking for evidence that there is end organ damage as a result of the overactive parathyroid. So by looking for the evidence of, you know, high levels of calcium in the urine, whether there's been renal stones, whether there's evidence of osteoporosis, whether there are other symptoms associated with the high calcium, or whether the degree of hypercalcemia is worrying. But I don't think in MEN1 often, so the glands can be affected at different times and are often become, all 4 glands can become enlarged, and we haven't established a clear, so if there was a clear indication for surgery, then surgery should be performed. But if there isn't, we know it's not going to go away and it occurs at a young age, therefore it isn't always clear what the best time for surgery would be.
Sort of watch and wait.
Well, I think that becomes a discussion as to, you know, when you know that the problem isn't going to go away, then to some extent there may be some argument for getting on and going down a surgical route, but then there is morbidity associated with the surgery, and even undertaking the surgery there is still a possibility of recurrence following surgery. So these guidelines by no means have all the answers, and what I don't want to do is give a, you know, this isn't necessarily about my point, kind of my point of view, but yes.
With transplant, is that a possibility after all the glands have been removed in the past, or do they do that at the same time?
They would do it at the same time.
So you wouldn't be able to have that done like retrospectively?
No.
Right, okay.
So the autotransplant is based on taking viable cells from the parathyroid gland at the same time of surgery. Sometimes they can be cryopreserved and put back in at a later point, or they're put in kind of simultaneously.
Okay.
But if the glands have been taken away, you know, the options for retrospective implantation have been missed.
I thought maybe there was a chance that somebody else could donate a...
I don't think that's...
We used to do the autotransplantation, and actually we stopped doing it
The autotransplantation is very popular outside of the UK, I think, but I mean, certainly in Oxford we don't recommend it. I mean, clearly if you're putting the same tissue back in, there is still a likelihood, there's no guarantee that it will work, because you're putting the tissue, you're doing an operation, you're handling the parathyroid tissue and you're putting it somewhere where whether it works or not at that point, you don't know. If it does work, the possibility is that it's the same tissue there, so it could still be affected by developing the high calcium again in the future, in which case then you need to take it out. So I would say that typically in the United Kingdom we don't routinely do autotransplantation, but certainly there are people who are very keen advocates on the authors of these guidelines, and that's why, and certainly in Europe it's done, and certain parts of the States it's done.
We have had one patient where it was difficult to find it in the forearm, basically, which was the whole issue. And first we stopped.
So the screening for pituitary tumours, I think, is probably the most straightforward, in that many of the most common types of pituitary tumour in MEN1 are prolactinomas, which can be identified by a raised prolactin level in the blood, or acromegaly, or the secretion of too much growth hormone from the pituitary, which can be detected by or screened for by a single blood test. However, because we know that some tumours within the pituitary can be non-functioning or non-secretory, then we do recommend doing imaging every 3 to 5 years to look at the shape of the pituitary gland, or sooner if there are any symptoms to suggest there is a pituitary tumour there. And the treatment of MEN1 associated pituitary tumours is exactly the same as that of those with sporadic pituitary tumours, in that if it's a prolactinoma, then that would typically with tablet treatment. If it's acromegaly or growth hormone producing tumour, it might be a combination of medication and or surgery. And if it's other forms of tumour which reach a particular size or are problematic, then pituitary surgery and or radiotherapy would be the treatments of choice. So I think by far the most difficult area for the management of MEN1 is for screening and treatment of pancreatic or the kind of neuroendocrine tumours associated with MEN1. So we feel that screening for gastropancreatic NETs should include as a minimum an annual plasma biochemical evaluation of the gastrointestinal hormone profile, including a measurement of gastrin, glucagon, the VIP, pancreatic polypeptide, chromogranin A with insulin, and fasting glucose levels. And a consensus for the optimum radiological screening program has not been identified, but we feel some form of annual imaging should be undertaken. The most sensitive screening modality to detect any abnormalities within the pancreas or duodenum is probably endoscopic ultrasound, although the provision of this on a local basis to the is quite significant. It would be a service that would be quite difficult to provide on an annual basis. We favour magnetic resonance imaging at the moment as to avoid the exposure to frequent doses of ionising radiation. So in terms of the treatment of pancreatic tumours, I mean, I think the ultimate goal is that, so the main aim is to maintain patients disease and symptom free for as long as possible and to maintain a good quality of life. I mean, that's goes without saying. And the treatment for those with functioning pancreatic tumours, including insulinomas, would be curative surgery where possible. But prior to doing any form of surgery or intervention, it's important that there is a thorough evaluation of the extent of the disease. The treatment of gastrinomas is controversial, and I think that's probably the most important message, is that we don't have a right answer for this. So one area where it is quite clear is in the rare occasion where gastrinomas occur within the pancreas and reach a certain size, which, if they're a well-defined gastrinoma within the pancreas, we feel that surgical treatment should be the treatment of choice. But in MEN1, the majority of patients with gastronoma, these are multiple, they're small, they may be microscopic, and they tend to occur within the duodenum rather than the pancreas. In the UK, we have tended to favour medical management, and this has been based on with tablet treatment, proton pump inhibitors. This is based on that previous surgical series show that in MEN1 patients, if you undertake surgery, you rarely cured the problem. However, there is more recent evidence that suggests doing extensive surgical procedures by very specialised centres may provide a curative approach to these tumours. But we feel at the moment the evidence for that, so the strength of that recommendation is weak and the evidence for that is not clear-cut. But people have recently reported curative approaches to duodenal gastrinomas. And then an area that again is difficult is one of the most common groups of tumours in MEN1, non-functioning pancreatic tumours. And these are important because in the largest series, this is now one of the leading causes of death in MEN1. And so in the past, it was typically associated with gastrinomas, which were untreated, leading to peptic ulceration and hemorrhage. But with the advent of medical treatment, people are typically identified at an earlier time point and are treated effectively. And so one of the most difficult tumours to deal with now is the non-functioning pancreatic tumours. And again, the optimum management of these tumours is not well defined. However, we recommend considering surgery, and we're not saying undertaking, we're saying considering surgery for any tumour that's more than 1 centimetre in size and or demonstrates significant growth over 6 to 12 months. Other groups would typically use 2 centimetres as the cutoff. And the reason for this recommendation is in the series of patients where they've looked, there seems to be a correlation between the size of the pancreatic tumour and its ability to spread elsewhere. So that the bigger it is, the more likely it is to spread elsewhere. And certainly above 4 centimetres, or between 2 and 4 centimetres, the risk of it having spreading elsewhere is increased. Below 2 centimetres isn't clear, and less than 1 centimetre the risks seem quite low. However, there are other studies where that correlation hasn't been identified, and therefore I think our guideline is quite cautious in that we are saying consider surgery really for any tumour that's greater than 1 centimetre or one that is showing a change over a relatively short period of time. We've included in this the importance of having pathologists, so the people who look at down the microscope at the tumours, to be able to grade the tumours appropriately. And for those in whom surgery isn't appropriate, then there are other therapeutic options, including somatostatin analogues, biotherapy, forms of radio-labelled treatments, and chemotherapy. And for those patients where there is metastatic disease or where there's advanced disease, then typically chemotherapy is used, and the use of newer agents such as drugs called mTOR or tyrosine kinase inhibitors may be effective for individuals with advanced disease. Adrenal tumours haven't typically formed a large part of kind of recommendations in the past, although we're aware of a high prevalence of people with adrenal tumours in MEN1. And therefore we recommend a kind of a minimum screening protocol of looking at the adrenal glands up to every 3 years, and that if there are abnormalities there, that they should remain under radiological surveillance and should be assessed for any features which suggest they may behave in a malignant fashion. And that biochemical evaluation, so this is looking for adrenal tumours that are secreting too much hormone that may be associated with high blood pressure or too much steroid production, should be focused on those with tumours greater than 1 centimetre in size. And the treatment of these is similar to those individuals who have sporadic or non-MEN1 associated adrenal tumours, and surgery is indicated either for those that are producing too much hormone, where there will be a cure to that hormone excess by surgery, or for those that have any form of atypical features or are greater than 4 centimetres in size, or we qualify that by saying or that show a change over a 6-month, a significant change over a 6-month period. And finally, focusing on bronchial and thymic carcinoid tumours. Bronchial carcinoid tumours in European populations tend to occur more frequently in women, whereas thymic carcinoids occur more frequently in men. That isn't the same all throughout the world. For example, in Japan, thymic carcinoids have an equal sex distribution there. So we don't differentiate by sex in these guidelines. And here we recommend imaging of the chest, so by that I mean the lungs, every 1 to 2 years for the detection of these tumours. And that here the treatment of choice would be curative surgery where possible if the tumour was localised to a single area. If it's spread elsewhere, then additional therapies may include radiotherapy and chemotherapy. So this is a kind of an overview, which I don't know whether it may just be worth just walking through, just kind of it's kind of a summary slide of what we've said. So if we make a clinical diagnosis of MEN1, if we start at the top, if there's a clinical diagnosis of MEN1, so an individual with 2 or more MEN1 associated tumours, we think the first thing to do is test for an MEN1 mutation. If an MEN1 mutation is identified, then we should be thinking about 2 things. The first is to going into a program of biochemical and radiological screening, and the second is to be thinking about the rest of the family. So identifying first-degree relatives. So this is an individual with a known MEN1 mutation in whom we can screen family members for that mutation. And for those family members who don't have a mutation, then clearly at that point no further investigation is required. For those who do have mutations, then they will come back now into the screening protocol as per their relative. If an MEN1 mutation isn't identified, then this raises a number of possibilities. So this could be the 10% of individuals in whom we don't find an MEN1 mutation. It could be due to the presence of mutations with other genes that we do know about, depending on the clinical situation, and therefore we will consider doing mutation analysis of other genes known to be associated with tumours that can occur in MEN1. But for those with a clinical diagnosis of MEN1 in whom we don't identify a mutation, then we can still consider a form of limited surveillance, depending on whether or not they have the extent of their clinical features. And in addition, we should still be identifying first-degree relatives as those individuals and offer some form of biochemical and radiological screening, knowing that they will not, that they're not going to have the MEN1 mutation. So once we've entered the screening program here, if everything looks normal on the annual screening, then we simply go into a standard follow-up with biochemical or radiological screening, typically on an annual basis. If there is any abnormal result, this will prompt the need for further treatment or investigations at that point. So in summary, I think the key messages are really that the optimum management of MEN1 associated tumours isn't clearly defined for each of the tumour types. The key message is that individuals with MEN1 should be being managed by a multidisciplinary team consisting of individuals with expertise in the management of the tumours arising in MEN1. And that these guidelines simply provide a framework for providing patient care, but the exact detail of what is provided locally will depend on local resources, patient preference, and these are going to inform the kind of decision-making process. And I think that's it. So thank you very much.